welcome to Dr. Ronald Zucker, who's a plastic and reconstructive surgeon with the Hospital for Sick Children and also a professor at the University of Toronto's Department of Surgery and a TF board member. Welcome, Ron. We're very excited to have you lead the discussion today and look forward to you sharing your expertise with us all.
Thank you very much. This roundtable is going to try to find some solutions to the issues related to palate repair, to make them safe and to try to get them as timely as possible, because as we all know, delayed palate repair can have long-term consequences that we would like to avoid. But on the other hand, it is critical that we do this safely and that we do this with the families' best intentions involved so that they all are able to travel safely, they're all able to have safe surgery, and they're all able to hopefully have it in a timely fashion. Our panelists today are Dr. Galiwango, Dr. Florin, and Dr. Chiruji, and I'd like to introduce first Dr. Galiwango. He's the head of the Plastic and Reconstructive Surgery Department in Korsu in Entebbe, Uganda. He completed his higher surgical specialty training in plastic and reconstructive surgery with COSICSA, and serves as a mentor to the clinical education to budding plastic surgeons across Uganda, which is so critically important. Dr. Galiwango's experience spans over 10 years, and he's worked as a senior teacher with Korsu's comprehensive Cleft care team. Dr. Galiwango, please take it from here. Thank you.
Glad and honored to be here to present to you all in this once in a lifetime opportunity. We're all doing this for the first time and struggled with coming up with something to talk about regarding path forward for safe and timely palate repairs in Uganda. But here we go. My name is Dr. George William Galiwango. I'm a plastic and reconstructive surgeon at Korsu Rehabilitation Hospital in Uganda. Korsu is a hospital found in Uganda, which is in East Africa, and that's the black dot you see over there. That's where Korsu is situated. Uganda is about over 40 million people population, and Korsu serves most of the clients that come from all over Uganda and also neighboring countries. We are a rehab hospital that covers mainly orthopedics and plastic surgery for children, but mostly for people with disability. We are a 100-bed hospital, specifically for cleft surgery, comprehensive cleft surgery. We have surgeries in the theaters, we have operating rooms, we have outpatients clinics, speech and language therapy, speech therapy, nutrition, and dentistry, which is something that we want to get on board, as well as ENT. What have we suffered as a country and specifically the hospital in this COVID-19 era? There's been lots of anxiety amongst the staff, reduced surgeries, and this led to loss of income to the hospital, and then subsequently scheduling problems in Q4 as there was been a relaxation in the restrictions. On the patient side of things, there was transport restrictions and increased transport costs, and these were a result of the restrictions on transport during the lockdown, which happened between March and June. There were increased food costs, reduced access to health facilities, reduced outpatient visits, and all this managed to lead up to a malnutrition amongst the patients. In fact, there were some deaths that were reported when we called up families. These were attributed to malnutrition and respiratory infections, especially in patients with cleft lip and palate. The numbers, this is what happened. We started seeing fewer patients attending our nutrition unit. The surgeries were also dropped down to 0 between April and May, until when the restrictions for cleft surgeries were opened by Smile Train. And again, the cleft palate numbers were also down similarly. From June onwards, we've seen a sharp rise in patients coming into our clinics, a sharp rise in patients attending the nutrition unit. Most of them are malnourished, and most of these are mainly patients with cleft palate. What was our response as a hospital and as a cleft team at Korsu? During the COVID time, we increased the patient follow-up calls. We were calling up the numbers that we knew were on and those that could respond to us. Just finding out how they are, and also letting the patients know that we are open for those that could get to us, and also advising them on nutrition aspect of things. We also increased, with help of Transforming Faces and Smile Train, the transport costs reimbursements, and these helped patients be able to travel to the hospital and stay at the hospital for the treatment they needed. We revamped the nutrition rehab program and energized it, funded it more, increased the vigilance so that they could cater for the increased malnutrition that they were seeing during this time. One of the main things that we did was prepare a food package for patients that were highly at risk of malnutrition, especially when they were not fit for surgery but needed to go back home and continue rehab. There was increase of education during the hospital visits in the area of nutrition, and also a talk show was planned, and this was to highlight nutrition for the cleft palate child. This is what we noticed before the lockdown, that the proportions, which is what has been going on over the years, the proportion of severely malnourished children, that's the slice in blue, moderate malnutrition, and then those at risk. This was before the lockdown. During the lockdown, of those that turned up to the hospital and those that we managed to get on phone, were showing that there was a sharp increase in those at risk. And when the lockdown was lifted somewhat, we noticed that of those that turned up at the hospital, a higher proportion of those that were being seen as moderate risk and malnutrition were being seen. The proportion of those at risk reduced because the one of malnutrition increased quite sharply. What did we do about this? Like I mentioned earlier, the patients were being educated more while they were at the hospital, but also we started to come up with these food packages, as you can see in the pictures here, that we were giving them as they went back home. We keep the patients here for an average of 2 to 3 days as we educate them, especially when they are not severely malnourished, and then we give them these packages so they can travel back home and be able to feed these children for the next maybe a month of this that is highly nutritive. On resumption of surgeries, we carried out a strict pre-admission checklist, taking history and temperature so that we don't put the hospital and other patients at risk, taking a child or family that is was exposed to COVID. We increased the vigilance on the ward, and then also the pre-anesthetic checks were actually much tighter to make sure we do not put the hospital and patients at risk. The anesthesia, the surgery, and the care in the recovery room is under strict PPE so that both the staff and the patients are safeguarded. What are the key takeaways from what has happened for us at COSU during these months and going forward is that many of the cleft palate patients are at risk, but those that are adversely affected are the under 5s. Amongst these, we've noticed increased levels of malnutrition. And what are we doing about this? We are enhancing the nutrition program with both staff and materials. We are skilling them up. Many of the staff members in the nutrition unit are on programs, learning, getting better skills at managing cleft patients with a cleft lip and palate. And then there's increased sensitization of families on nutrition. There's nutrition packages, like I showed earlier, being given out to those families with high food insecurity. There's high security, high safety SOPs in place for resumption of cleft surgeries. And then also on the surgical side of things, we are prioritizing the cleft palate patients so that we can deal with the backlog in the shortest time possible. Of course, taking in mind that these patients would have to be fit for surgery in the first place. With that, thank you very much. Mubalenyo, like we say in these parts of Uganda, and more so to all the participants and our kind donors, Smile Train and Transforming Faces. Thank you very much.
Thank you very much, Dr. Galiwango. Thank you for your wonderful presentation outlining the importance of nutrition. And I think we'll have a chance to discuss that in the discussion period that will follow. But now I'd like to introduce our next speaker, Dr. Carla Florin. Dr. Florin is a cleft surgeon, and she works mainly at Fundación Gantz in Santiago de Chile, where she is the head of the pediatric plastic surgery unit at Sotero de Rio Hospital in Santiago. She is a pediatric plastic surgeon trained in Chile with a cleft fellowship at Great Ormond Street Hospital in London, UK. She now teaches at the Faculty of Medical Science at the University of Santiago and is a reviewer of the International Journal of Pediatric Otorhinolaryngology. I'm pleased to welcome Dr. Carla Florin to our roundtable. Carla.
Good morning. My name is Carla Florin, and I am one of the cleft surgeons at Fundación Gantz. This is Fundación Gantz. It is an NGO founded in 1978 whose aim is giving a comprehensive care to cleft patients. It is one of the national cleft centers authorized by law to treat cleft patients in Chile. Our patients come from different parts of the country and from other countries as well, and we perform missions to southern Chile every year. As many other countries, COVID-19 has been a huge impact. The first case in Chile was in March, and the cases have been rising since then, as you can see from the chart of the cumulative cases. At the beginning of the pandemic, a system of dynamic lockdown were implemented. The Ministry of Health redistributed resources, intensive care units, beds, ventilators, etc., from public and private hospitals, and the non-emergency surgery was suspended. Therefore, everything was cancelled, including cleft surgery. Then, the lockdown became permanent and grew in area. This lasted for almost 20 weeks, leaving us a big waiting list. In August, the infection index and the ICU occupancy were improving, allowing us to restart surgery. But how? Taking into account that COVID-19 will stay for a while, a special committee was created in order to prepare for resuming our work, and its first goal was to get information from Asia and Europe, and that had a couple of months of pandemic ahead of us. Sometimes it appeared quite clear, but others became overwhelming because new information came out every day. However, some statements were globally accepted, like cleft surgery is a procedure with high risk of aerosol spreading. Therefore, how we can decrease the risk of exposure? From that, other questions came through. What are the appropriate PPE for cleft surgery? What happened to anesthetic and operating room? And on the other hand, there are patients. Which of them will be prioritized? What requirement they should meet? What about preoperative preparation? Therefore, they were looking for specific recommendations from other surgical areas. Once information were on the table, it was compared to the resources available at Gantz and decided which requirement will be adopted and which one will be adapted to our reality. Basically, this planning can be divided in three main groups: protocols, equipment and PPE, and building facilities. The more challenging was providing equipment and PPE because of shortage of them and the high prices. Remodeling of the building facilities were done, and PPE and other equipment were obtained after hard work. The new protocol was presented by online meetings in order to inform and receive questions and suggestions from the rest of the team. Here we are, a brief comparison between the old protocol and the new COVID protocol. At the moment, we are prioritizing to operate on patients who their primary surgery were postponed and don't need an inpatient post-operative care. As you can see, COVID PCR, auto lockdown, and a COVID questionnaire are the main differences on pre-surgical evaluation. This is in order to reduce the number of in-person assessments. On the same day of the surgery, the patient is admitted and evaluated by the anesthetist and the surgeon. Consents are also done and questions are answered. The main difference is that only 2 patients are operated per day. Being accompanied with a caregiver during anesthetic induction is allowed wearing PPE, and surgical team must wait to get into theater until the airway is secured. Then, palate repair is performed by a standard technique according each surgeon. The main difference is wearing more PPE than we used to, and the ritual that must be followed closely during putting on and taking them off. The emergence is done by the anesthetic team alone, and the recovery is done for one patient and their caregiver per room. The patient is discharged with prescriptions and instruction of care. The follow-up during the first week is done by telehealth, whereas before was done in person. COVID-19 has been a big challenge for everybody, and as a Cleft Center, we are trying to keep going on with the same quality of care in these difficult times. Procuring PPE has been the most difficult part of the preparation due to the shortage of stock and the higher prices. We are glad to have a good communication with patients who understand and accept this new way of giving care to their children. And the development of a new technology has contributed to keep the quality of care. However, it must be taken as a complementary tool. Thank you very much for your attention.
Thank you, Dr. Florin, for a very clear presentation. The way you use your PPE in the operating room is very interesting, and I'm sure will generate some discussion. And thank you for showing us the pre-COVID and the COVID techniques, both preoperatively, pre-surgery, during the operation, and post-op. We'll wait for the discussion after our third roundtable presenter, and I'd like to welcome Dr. Chatterjee from India. Dr. Chatterjee is an oral and maxillofacial surgeon and project director of the comprehensive Cleft team in Kolkata at the Kolkata Cleft Center. His MDS was awarded at Rajiv Gandhi University in Health Sciences in Bangalore, and he completed his Cleft and craniofacial surgery fellowship with the Smile Train Partnered Hospital mission of Mercy Hospital. He is a partner at the ABMSS, DCKH, and of course, Transforming Faces. So welcome, Dr. Chatterjee, to this roundtable. We look forward to your presentation. Thank you.
Good evening, everybody. This is Dr. Siddhartha Chatterjee from India, and I'm speaking on behalf of ABMS Cleft Care Center at Sri Jain Hospital, which is also situated in India. And today we are discussing a very useful or important topic, which is resuming cleft lip palate surgeries, or rather palate surgeries, into the post-COVID era. I'll introduce myself first. This is Dr. Siddhartha Chatterjee. As I told you, I worked as a project director and chief craniomaxillofacial surgeon at Comprehensive Cleft Care Center for the people of West Bengal, and my center is funded by Deutsche Cleft Kinderhilfe, AVMSS, and Transforming Faces. As I show you the scenario currently in West Bengal, this is the bulletin published on 8th of September. In the first graph, as you can see, that the COVID test numbers have hugely or steeply gone up, and it has reached up to the peak of nearly 25,000, more than 25,000 cases a day at itself in West Bengal. And off lately for I think 7 to 8 days, just the peak is little bit sloping downwards, and we are hoping for a better future, but still you never know when the second wave is going to hit. The testing per day has also increased up to 45,000. So out of them, 25,000, 20 to 25,000 have been detected positive. This is quite alarming. And in this scenario, we have to be really safe in doing cleft lip and palate surgeries, since primarily we are dealing with the oral cavity and the mouth of the patients, and which is where the COVID virus or the SARS-CoV virus stays. So the status after opening my center, after a nationwide lockdown from March to June, we resumed around 15th June, and in June itself we were able to perform 20 surgeries on that month, and in July 26 surgeries, and in August around 16 surgeries, and in September around 15 surgeries till now. And speech therapy online session has been a great number. which is 177, and this is mostly done online. No patients come to the center for speech therapy, and this model has been working great. At times we expected around 4 to 5 sessions a month for the patients, but the patients never used to travel that amount of time to the hospital. But due to this WhatsApp therapy or the online therapy, it is quite encouraging for the patients, and they are attending all the sessions. But dentistry, which includes periodontia and orthodontics, has been limited since the outdoor is not working fully. So just we started around a few NAM cases of late, and we hope to do more number of cases with a safer protocol. Challenges as of now, how we maintain the protocol now. The patients are first admitted to the isolation ward, which is one female and one male, and the babies with their mothers are mostly admitted to the female ward. This is situated inside the hospital, but outside the hospital building, uh, in the hospital premises itself. So first we admit the baby there, then COVID test is done, and once the baby is negative, then only they are shifted to the cleft ward. Now, in spite of they being negative, still we maintain a safe protocol with PPEs. As you can see, the anesthetist and the assistant wearing a full gear, because the sensitivity of the COVID test is around 70%. Still 30% can, there are chances that it can go for a miss. So we don't take any chances, and we use the PPE equipments for the safer surgeries. Now the challenges which has come to us post-COVID era, of course, there is the risk of exposure greatly, but the cost of the surgeries have gone up due to the more use of the PPE and safety equipments, maintaining the separate isolation wards and COVID tests, which are being mandatory for all the surgical cases. This all have summed up to a plus amount of charges for the surgeries as used to happen before. Now the external challenges what we are facing is the travel restrictions. Now the interstate train have not yet started, so the people have to, or the patients have to avail only the bus services from distant places to come to Calcutta. That is also limited in number, and most of them are scared to travel to the cities. In the villages, the number of COVID cases are less, and they are very fearful to travel to the cities. But somehow by constant encouragement or counseling by the project coordinator and the social worker, we are getting good number of cases as of now. Now the main problem is dealing with the underweight babies who are supposed to come to the hospital every 15 days, but now due to that public inavailability of public transport, they are not able to come to the center. But we try to give online counseling or over the phone, but which we feel is not adequate. The backlog of the cases which happened due to the nationwide lockdown has mostly been cleared now. In these photos, as you can see, it is all the screenshots taken from the phone, that how we do a online OPD. The first case is around 10 days post-op. The next one is a pre-op case which has been sent directly from the home. The other one also, and the upper row, the last one we can see, that is also a 7-day follow-up of a unilateral lip. And the down photos are all of speech therapy except one. As you can see, the down here, the speech therapist is speaking to the patients and trying to give them adequate care over the phone itself, and doing a regular follow-up after what he has done in the first session. Now, few protocols which we have made, which are we feel mandatory for safer palates repairs, is use of 3M or the Shingematsu respirators during the surgery. This is how they look, and no smell comes inside. So inside, when we are wearing this mask, so that the fumes which are generated from the cautery while doing the cleft surgery, or the aerosols which are generated by the anesthesia machine does not come inside. And we do a mandatory COVID test. Except all these things, we also use the PPEs, the face shields in the wards for the taking care of the patients and the nurses as well. Only online post-op assessment is done, and routine antibody testing is done for all the doctors, nurses, and social workers, so that we are safe. And some minor adjustments like less judicious use of cautery machine, use of tight throat packs, cleaning the oral cavity with betadine solution before the surgery, use of high power vacuum suction, these are all included in the protocol for our safer repair, so that the surgeon, the assistant doesn't turn COVID, and including the anesthetist and his co-workers. Now the post-op care, we only do the virtually through the WhatsApp, because we don't encourage the child again to come to the hospital setup where other COVID positive patients will be there. And so we do a 7-day follow-up, 21-day follow-up, and a 1-day follow-up through WhatsApp, and the coordinator takes care of this. The counseling, as I already mentioned, the people are scared to travel to the cities now. So the counseling is done by the project coordinator and the field worker due to COVID related barriers to address the issues that the families are facing due to access, the timely surgeries, the transportation cost restrictions, and fear of hospitals are all taken care. The post-op care has mostly been done by WhatsApp video calls and photos. Now the center was closed for a period of about 3 months. So there was a backlog at around 80 to 90 cases. And if we take an average surgery of our center to be around 30 to 35 cases a month, but we have been successful in clearing around 60% backlogs in the month of July, August, and September. And newer cases have also been addressed along with this. And we feel that we'll get back to normal gradually, and there should be no problem in the coming months, and we should all be COVID free when the vaccine comes in. Now the potential risks include that if any team member may turn positive in this future, and 3 babies of the total backlog what we have cleared were detected of SARS-CoV positive in this period, but the protocols were implemented to keep the baby safe, and a 3-week post repeat test was done where they turned to be negative and safer surgery was conducted in them. Now the key takeaway for the participants, that first be safe, then ensure safety for your team. The use of, please use 3M respirator mask during the surgery. They're quite useful and will keep you safe. And do mandatory COVID tests for all the patients, even if your country doesn't have in the guideline, but still you do for yourself and the safety of your team. And use the PPEs or the personal protection equipment. And for the time being, you can avoid adult cleft surgeries. This is the hospital where I work with, and Sri Jain Hospital and Research Center, and this is the team. We hope for the best during the post-COVID era, and everybody should stay safe. Thank you.
Thank you very much, Dr. Chatterjee. We appreciate the information that you have provided for us. Travel is a particular problem, so I really appreciate you bringing that forward for our roundtable discussion. We're finished with the 3 presentations now, so I'd like to start the discussion. Please unmute yourself and you can ask questions. I'd like to start it off by asking our first speaker, Dr. Galiwango, 2 things. You emphasized the nutritional issues that were that you had detected and how you improved them over time. What were your parameters? My first question is, what were your parameters to assess the nutritional status of the children? Was it just weight, or were there some other things? And my second question is, congratulations on ramping things up back to an almost normal numbers. And
Thank you for the questions. How did we manage to get the numbers up? I'll start with that one. It's because most of the cleft care was happening by outreaches. And because of the restrictions to transport and treatment of patients with cleft, most of those were being held back at home. So we managed to get funding from Smile Train and Transforming Faces to bring the patients in. This happened through a vigorous mobilization with our partner organizations and also the mobilizers that we usually use. So that managed to bring in more patients to the hospital. Regarding the parameters, our nutrition team uses weight for height and weight for age. And this again is followed up with what our Smile Train offers us regarding the assessment of the children for nutrition.
Perfect. Thank you very much. Clearly, the assistance with travel has helped your team to be able to deal with more patients than perhaps otherwise would have been possible because of the restrictions and the fear of travel. Dr. Chatterjee has mentioned the fear of travel as being a major issue with respect to his patients as well. Dr. Chatterjee, have you had any assistance with respect to travel, and rather than get on a bus with other people, is there any possibility of private transport for some of your families to perhaps mitigate their fears of travel? We have fears ourselves from a personal standpoint on going on public transport. Our nurses do, and everybody does, but is there any opportunity for private transport? Dr. Galiwango, did you want to continue that?
Regarding transport, sorry, I have some interruption with noise here. Can you hear me?
Yes.
Okay. Regarding transport assistance, there's actually little fear for transport in Uganda currently. People are quite happy to travel if they can get the assistance regarding reimbursement for their transport. So we're not seeing much fear for transport, especially to a hospital like ours, which is elective. To the bigger hospitals where they take in all manner of patients, I imagine there's people that are a bit anxious about getting in there, but certainly we're not seeing that in our hospital.
Thank you. Dr. Chatterjee, is there any opportunity for some kind of assistance with transport or protection of the children during their process of transport? That's one of the issues we'd like to discuss, safe surgery and timely palate repair, and transportation seems to be an issue. Any thoughts that this could be done?
Yes, definitely we can arrange some ambulance or bigger or a smaller bus from the hospital to send to a corresponding district from where the patients are coming from, and maybe we can do that, and so that they are safely brought to the hospital and then again sent back to their home safely. But again, it is going to be cost effective, cost incurring for that. And as of now, the patients with their babies are avoiding the public transport. What they do, suppose 3 admissions are there from one district, they're hiring a car or a small bus by themselves and coming to the center.
I think, Dr. Florin, your patients are admitted the day before. They're treated as inpatients, which increases. Is
No.
that correct? Or was that the presentation from Argentina? I can't remember.
Yeah, no, we don't have in the center, we operate on patients that they are not treated as an inpatient.
Oh, right.
If someone needs for another condition or an associated pathology that requires to stay in the hospital for at least one night, we had like a collaboration with a private hospital, which is a big one, and all the patients are operated there. So now at the moment we are not allowed to start operating them yet. Just wait for the permission to do it, and then we have a waiting list for that.
Have you encountered any of the nutritional issues that some of the other teams have encountered with the babies?
The question is for me, yeah? No, not really. We are lucky, I think. We had some well, during the pandemic, it was a very difficult time. So there were some people that lose their jobs and they had some problems, but we are lucky that at the moment we don't have any like a nutritional inpoor nutrition problems. On the contrary, we had a high wait
list. Yeah.
Yeah, that's our problem.
Okay. Are there any questions from the audience out there? I'm sure there must be many.
It looks like Ron, Matt Fell had a couple questions.
Oh, good. Hi, Matt.
Hi there. Should I sign them out, shall I?
Please do.
Just for Dr. Chatterjee, it's really amazing to see that you got through 60% of the backlog. I just wondered how you did that in terms of, did you need to raise extra funds or get extra theatre space out of normal working hours, or was it within working hours and other operations were cancelled to make space for backlog?
Yeah, thank you for the question. Yeah, we have a separate cleft operation theater in the hospital, only dedicated for cleft patients. So cancelling other operations was not an option for us. And what is your other question?
How though did you get more productivity out of that if you had continued to have the normal amount of patients coming anyway? How did you get through that backlog? Did you have to work out of hours or stop doing other cleft operations?
No, see, new surgeries were coming in less. Suppose we do 30 to 35 cases a month of cleft. So new surgeries were less. So during that time, we cleared the backlog.
Great. Thank you. I think it's very helpful to have your own cleft operating room and you have your own, have control over what you're going to do and what you're not going to do, because prioritizing cases then becomes relatively simple. If you're in a small group, you can prioritize amongst your own little family, so to speak. But if you're in a very large institution, I think it's quite a difficult situation, and it's hard to push cleft care, unfortunately, to the top of the list when we're dealing with so many other concomitant problems in a major, large institution.
I believe, Ron, Dr. Summerlad put up his hand.
Yeah. Yes, Brian. Glad to have you here.
I'm just thinking about the risks to the versus benefits for the patients. So we're, on the one hand, we want to repair the palate at the right time, at an ideal time. On the other hand, we want to reduce the risks to the patients. What are you saying to the and this is happening in the UK also. What are you saying to the parents about when they try to make up their mind about that timing? What are you saying to them about when the palate really should be repaired by, and how long they can actually, or how long can they wait before it is important that they have the palate repaired?
Thank you. In general, most protocols are like 12 to 15 months. And then it becomes questionable as to whether or not normal speech will evolve. Is there anybody in the audience that'd like to take that on? Karen, are you there?
I am here. Thanks for having me. I'm Karen. I work in Canada. We've been telling our patients that we would ideally like to get to the palate repair before 18 months, although we know that between 15 and 18 months is probably already putting some kids at higher risk, just because it's variable how quickly kids pick up speech. I don't think every child is learning how, or learning a large number of words necessarily between 15 and 18 months, but we do think that delaying any further than that is certainly putting their speech at risk. We're lucky that we have a great team of speech and language pathologists that will support these families through it, but I really think that we can make a good argument about putting their speech at risk for the long term in advocating for our patients to be done at an earlier age.
Thanks.
Can I comment this?
Yeah, I'm Conan.
Yeah. Nice to see you. Thank you. Yes, in the standard is as you said, but we have reasonably good results for those patients who are operated late, even in adulthood. So when we compare the risk to exposure and the speech outcome, I think if the risk is not getting less, maybe better to delay the surgery. And I have, saying this, I have one question to all of the surgeons. The big problem here is that we don't have a separate place to lock down the patient. The patient comes and we don't get the COVID results immediately. It will take some days And where do you put your patients during this time? The surgeons. Do you have a separate place to keep the patients until you get the result? And the other thing is, one of the surgeons says that they regularly check staff for COVID. How often they do? Because they can have an exposure anytime. I mean, if they check today, they can be exposed just tomorrow. So how is this really practical?
Excellent questions. Excellent questions. In terms of testing, after the tests are done, we like to insist that our patients be isolated, but they're under self-control, that they're not locked up in any particular barrack or anything like that. They're trusted that they will not expose themselves to the community until that surgical procedure takes place. Carla, what do you do at Fundación Gans? I think you had a 2-week, I think you said that the patients will be isolated for 2 weeks prior to surgery?
We encourage them
do they do that at home, or where do they do that?
At home, yes. We encourage them to stay as isolated. The patients, the baby, and their caregiver, that usually is the mother. So we took them as a unit, as a unit, and we encourage them to stay isolated for 2 weeks or 10 days, 14 to 10 days before the surgery, and then take the COVID PCR 2 days before surgery, and then to do an isolation for the post-operative period as well. So they can just come to the only for the follow-ups. Can I add a quick question about Mr. Sommerla's questions? Because this is in terms of the age of the cleft surgery, because this was one of the main difficulties that we had at Fundación Gans, because before 2015 we had a very we operating in the mean of the 15 months of age, so we consider that it was too late. So on this the last years we are trying a very hard work to trying to operate earlier, even before 12 months of age. And then now with the COVID is more difficult, because we seem that all this hard work trying to operating before is just like putting on the bin. So it's difficult for us and difficult for the patients and parents as well.
Thanks, Carla. We had a good question from Donald Malombo asking about how online post-op tests or assessments are being conducted. If anyone can weigh into that.
Can I say? Well, I show on my presentation that before we do mainly just one phone call at the second day. Because you know, in Fundación Gans we are not a space to take inpatients, so we are just discharged on the same day. So we usually we used to call the patient at the second day post-op, and then they come to the follow-up in person. But now everything is done by telehealth, and we trying to reduce the in-person assessment just 1 or 2, whereas before it was 5 if it's necessary.
Thank you, Dr. Flor. I'm still waiting for a good solution to Dr. Summerlad's question of the balance between the risk of bringing the child into the operating room and the risk of waiting. Brian, it probably depends on the family situation. We know that children don't get that ill from this virus, and we know that they may spread it, so that we have to take precautions. But if that child is living with some older people who are at risk with other conditions, elderly or patients that are obese or hypertension or diabetic or whatever, then there is an increased risk of transmitting it to those other individuals. So I think that's one of the major issues that has to be taken into consideration as well. What is the social situation, if you like, of that particular child?
Can I just ask another question about, sorry.
Go ahead, Dr.
On the same, a related question, the medical legal aspects, more important in higher income countries, but are you adding COVID risks into your risk factors in consent forms? Is that a significant factor?
I can respond to that a little bit. I am discussing the risk a little bit more just because, you know, any patient who's at risk of an upper respiratory tract infection post-operatively is at risk of getting a dehiscence or a fistula, I think. And so we try to emphasize the importance of the isolation period for that reason as well, to make sure that they realize that the risk of a breakdown after the repair is greater than it would be otherwise, particularly for the palates.
Thanks, Karen. Yes, McConan.
Yeah, I think Dr. Brand raised a very important issue. We have not included in the consent form. So I think maybe it is important to include it in the consent. We are still using the consent form for surgery, the previous one. I think it should be renewed somehow. COVID should be included because COVID patients are at risk, and 30% false negativity is there. So there, and surgery, there are papers, the situation of COVID worsened after surgery. So I think it's important to include it.
Yeah, I would agree that something needs to be mentioned about the increased risk related to COVID for sure. Any other questions from the team?
It looks like there's a question from Edwin. Edwin, do you want to read it aloud? Otherwise, I'm happy to do so on your behalf.
Yeah, why don't you read it, Courtney, because I can't see it.
Yeah.
Go ahead, Edwin. His
well, I saw from Dr. Chatterjee's presentation, or was it? Yeah, I think it was some Dr. Chatterjee's presentation that adult palate patients are not prioritized. Does this have something to do with the benefits from the speech, or if so, what is the cutoff age for your adults?
The cutoff age for the adults is above 10 years, not 18 years. Yeah, above 10 years. We just say that if they have lived with if they have lived with cleft palate for 10 years, they can stay for 1 more year. No problem with that.
Okay, thank you.
Is that because you want to prioritize the younger children for palate repairs, or because there's increased risk of COVID in the adult patients?
Absolutely. We have reduced the numbers of fistula closure, oral lip revision, and adult cleft surgery for the time being. Only the primaries are being addressed.
Only the primary palates.
Primary palates and lips both.
So that your priorities are prioritizing them because of the potential speech problems with delay.
Right.
Yes. Okay.
Elizabeth, I think you had a question about palates. If you want to read that aloud.
Yes, but I was just interested to know how you are managing adult palates during this pandemic. Do you also do obturators?
Who'd like to answer that? are adult palate surgeries still being done in this era?
No, we are not doing adult palates as of now. We like to do them after 1 year, or maybe after the scenarios get better.
Okay.
What about for fistulas? Fistulas.
Fistulas also, as of now, we are not doing any fistulas, but we'll may take a call after 3 to 4 months if the situations are better.
Okay, thank you.
Again, is that because of prioritizing the primary palates, or is it because of an increased risk of COVID transmission with the adults?
The increased risk of COVID transmission, we don't want to expose them to the hospital scenario as of now.
So you have to remember that this is taking place in Calcutta, where there's a huge number of COVID cases in the community, and situation may be different in other areas of the world where the community transmission is less likely.
Right.
Conan, any comments?
I have a question to Elizabeth. Why she is mentioning about obturator for adults? Currently, we stopped. We are not operating any elective surgery, including COVID, including palates because of the COVID issue. But adult palate, I think, can wait. There is no need for obturator. What is her concern? Can she explain? Can you explain, Elizabeth?
No, because in Malawi, we do most of the other palates. We do the reserves. Wondering if we can also, if you're also able to do the obturators, just out of interest.
So I think the consensus is that they're probably best deferred until we're over this COVID problem, at least for now.
I think so.
The surgery.
And a number of people have touched on, obviously, the risks of bringing patients into the hospital, but some of the feedback that we've seen in the chat from people like Benjamin and Grace is some of the challenges around newborn nutrition, so patients not reaching a healthy weight by the time they arrive, and also around the availability of COVID tests. Grace or Benjamin, do you want to add to that at all or ask a question here?
Yeah, thank you very much. I only believe that our environment is a peculiar one in the sense that we are in the northern Nigeria where insecurity is a daily affair, and these patients are usually driven away from their environment by the bandits or by the by the Boko Haram. And so whenever they come to the hospital, they come and we check, we realize they are malnourished. What we try to do through the feeding allowance from Smile Train, we are able to give them some nutritional additives, which they cannot take them for more than 2 weeks, of course. But you know, when they get back to their location, coming again to the hospital is a major challenge because it may be at the time, maybe an attack has taken place in the environment. So they have left where they were for a hideout of an IDP camp, or the little cash they had with them has been exhausted and they may not come back. Sometimes when we succeed in getting them on the phone, is that maybe the patient has passed on. So it's actually a challenge in the sense that we don't have where to keep them for that period. And they also may not allow us to keep them because they actually stay in the remote areas and they're basically peasant farmers. They will want to stay in their environment. And then because of the COVID, what happens usually is that there are not enough kits to test even those who are symptomatic. So we are not allowed, because there are not enough kits, to test those asymptomatic prior to surgery. And it's not just for the cleft patient, but even for other elective cases. So the only thing we are left with is to see how we can use our PPEs to the maximum, which are also not available. It is a challenge, but we are grateful to Smile Train for what they have been doing. It has greatly supported us, and we are learning. We are learning from what others are sharing here. I don't know if they could also have suggestions to help us overcome the challenges we are going through. Thank you.
Well, thank you, and thank you for doing all you are doing to help these children, unfortunately, that are placed in this difficult situation. The nutritional issues are huge, and of course, we wouldn't want to proceed with any surgery just because they happen to be there and they're malnourished. That would lead to a disaster, which nobody wants. Any other comments? Karen has pointed out that there is reported an increased complication rate for surgery in adults on oral surgery, cleft repairs included. And that is one of the reasons why we would like to avoid surgery in adults, not just because they prioritize the children, but also because there's an increased complication rate. Does anybody know of any similar study or similar information with increased complications in children following cleft surgery? That's a question from Karen. Dr. Chatterjee, I noticed you had 3 kids that were tested positive, but you did not proceed with surgery.
No, not at all, not at all. We sent them home.
Was that because the anesthetist wouldn't give them an anesthetic? They were worried about spreading the virus to other healthcare workers, or was it because they were worried about complications of surgery?
No, the hospital only allow a surgery in a COVID positive patient in emergency situation, not for elective surgeries. Yeah.
So it was a hospital policy rather than a fear of a pneumonia or something like that post-surgically.
Right.
Any other questions?
Matt Fell had a question that was answered, Matt, but just around the threshold that most centers in this group are using for palate surgery and addressing backlog at the moment. So 15 months, I think, was highlighted by one of our panelists. And Matt is interested to hear how other centers are approaching that threshold in terms of prioritization for palate cases.
Any other comments? I know that McConnon doesn't necessarily think that proceeding with palate repairs at this point in time is worth the risk. Any other comments from other places?
Dr. Mahendale, can you say more about this study that you mentioned in the chat? That sounds like it would be of interest to this group.
I think, hi everyone, it's Felicity, sorry, I'll turn on the video. Felicity Mahendale from Edinburgh. We obviously, a lot of UK units stopped doing cleft surgery, so we've got a significant backlog. And we want to look at prospectively recording what the outcomes are for kids who have surgery in the wake of the pandemic and while it's still going on, and I suspect through the second wave as well. We won't be able to dissect out how much is due to COVID and how much is due to later operating, because I think sometimes the older kids are just that little bit more grumpy. I worry about operating on toddlers to do a cleft palate when they can be up and about and stick a pen in their mouth. I much prefer them to be 6 months, relatively immobile in bed. But what we're hoping is to get every unit in the UK involved with this, and we're also collecting some data on the impact of wearing PPE and operating, because that's easier said than done when you're wearing loupes or working down a microscope. We did wonder whether we should spread this out to other centers so that we have larger numbers to get some meaningful answers, which is always a challenge with clefts. But I think the main reason was a very sort of mundane, pragmatic one, that we weren't sure how long the regulatory paperwork would take. But if there are other centres keen, we would love to collaborate, because I think it will be a much more meaningful audit. So I'll give you my email and we can communicate. I'm doing, the Newcastle surgeons and I are the PIs. So yeah, I don't want to monopolise too much time, but maybe we could chat on email, and if there's other centres that would like to be involved, we have a sort of co-authorship model for anyone who contributes data. So I'm happy to share the protocol and information if people are interested.
Thanks, Felicity. That's welcome news.
And just to note that through Kiko Chat, you can reach out to Dr. Mahendale directly. You just, if you click through on the profile, there's an option to send an email if anyone's interested in the study.
There is a question about the reuse of PPEs, and are any centers reusing them? I noticed Dr. Chatterjee using the 3M mask that looked pretty involved. Is that a one-time use, or is it reusable, and how do you sterilize them? And are there other techniques of re-sterilizing the N95s? I know that one of the members of our group in Toronto is working on a technique of reusing, of sterilizing them so that they can be reused relatively simply with heat and humidity. Dr. Chatterjee, are those 3M masks reusable? And does anybody else have any comments on the reuse of masks?
Yeah, those 3M masks are, those are respirators actually. 3M respirators are reusable. They have a filter outside which can be changed every after 10 surgeries. And we disinfect it by using UV sterilization.
Mm-hmm.
By the method of UV sterilization every day, those are disinfected for about 35 to 40 minutes under UV light.
So is that a special UV machine that's necessary for that, or is it any of the other UV machines that happen to be in the hospital?
No, the few UV available machines are there now for the COVID scenario. They have brought into the hospital.
Specifically for these?
Yeah, specifically UV boxes.
I attended a webinar yesterday on the use of UVC light or far UVC for sterilization. And they say that you can use it for PPE, but they have some reservations about what that might do to degrade the plastic product, the plastic material of which the PPE is made. So I think I would be a little bit cautious. What we don't want is some plastic degradation products that we're inhaling on a regular basis. And these were sort of UV scientists who were talking about it. They were talking about a UV wavelength of 254 or 264 nanometers, which is not safe for humans, but 222 nanometers is safe to use around humans. But they were using the higher wavelength, the larger wavelength to sterilize PPE, but I'm not sure we have enough evidence on what it's doing to the mechanics of the PPE, the plastic. We know that UV light does not penetrate through plastic.
Yeah.
Thanks.
Yeah, I think the N95 we have, it says it's a single use. It is written on it single use. And we don't have the possibility of UV light and so on, but we are reusing it. We just keep it and then reuse the next day. Recently, we got a donation from Smile Train. Now we are in a better situation, but before, one mask is given like for the whole week by the hospital. So it is, we know that it is written on it, it's not reusable, but we use it.
Thanks, Makon. One of my colleagues here at Sick Kids is doing quite an extensive research project on the N95s to assess their reusability with heat and humidity, particularly heat at 70 degrees centigrade. And it's found to be very effective. And Felicity, they've done all of the tests that you've been mentioning in order to assess penetrability and degradation. And it seems to be working, and it seems to be a safe method of reusing them. So
that would be
sorry, just to flag to our group, there's just a few minutes left in this session.
Okay. one issue I'd like to bring up that was mentioned by Sarah before, and I guess it involves all of us in terms of collaborating between, if we look at the operating room team, and understanding their problems. The nurses have problems with fear of bringing the virus back home and fear of getting sick themselves because they have other responsibilities. The anesthetists have tremendous issues with respect to the fear of, again, transmission of the disease, and the surgeons want to get things rolling. They have lots of internal issues with their wait lists and with the patients that are backlogged. And I think it's important, as Sarah mentioned, to have a dialogue amongst all three members of the operating room and have sort of a sit-down session and maybe a little roundtable from each unit to discuss their problems so that we understand what the issues related to anesthesia are, that it is a much more difficult procedure now than it was pre-COVID. And we understand the issues of the surgeons that are pushing to get their backlogs finished, and the issues of the nurses who are fearful of coming in and fearful of getting sick themselves or transmitting it. And perhaps one way of mitigating all of this is to have sort of a huddle, a group get together where each team is able to explore problems and to have an understanding and a level of collaboration where we understand each other's problems. I know this has been an issue with my unit, where maybe we as surgeons don't understand the nurses' issues quite enough, and we don't understand the anesthetist issues quite enough, and they the same for us. So I think a sit-down session amongst the three groups for the operating room might be a good idea to have a discussion of what their problems are so that we understand each other.
Thanks, Ron. We're just into the last moment here of this session. So just to flag to the group, and I'll pass it over to you, Ron, for any closing remarks, but just to let the group know that the last session will be our closing plenary. There'll be a 5-minute break, and then that will start at 11:40 Eastern Time, 3:40 GMT. But in that in-between period, feel free to grab a water or coffee, what have you.
And you won't want to miss Dr. Mehendale with their plenary address in just 5 more minutes.
Great. Well, thank you very much, everybody, for attending this roundtable. We've looked at safety issues, and the safety issues are not just in the operating room, but they're all over. They're preoperatively, they're transportation-wise, with families being concerned about transport to the institutions. And it's not just in the hospital itself, it's also elsewhere, and how we manage post-operative care. We talked about the timeliness of palate repairs and how we can facilitate palate repairs at an appropriate time so that these children are not subject to potential speech issues, and how that can be done by prioritizing our operative lists, by working with our colleagues in our own institutions so that we can get these patients to the top of the list, and hopefully that will help to reduce our backlog and our wait lists. So thank you very much. Safety is our #1 concern, of course, but we also want our children to be able to speak properly in the most appropriate way and do the best we can to get a timely palate. Thanks, everyone.